Anyone concerned about risk in the emergency department? Bad outcomes associated with claims, malpractice, lawsuits, those type of things? I think it worries us all. So we're going to talk about how we can maybe standardize things. I mean, we've framed it as cookbook medicine, but really it's once you know there's a right way to do things, then that's the right way you should do them. And we'll discuss it more. All right, attributes of a medical malpractice defendant. We've got to touch on this first. So you kind of got to get a sense of who's at risk for a claim or a lawsuit. Things that do not correlate with claims. High productivity. I've had this question many times regarding, well, you know, if your docs are incentivized based on productivity and patient satisfaction, what about the docs that are pushing the curve on productivity? They must be putting themselves and their patients at risk. Actually, studying this over the last several years, that isn't the case. They tend to be better docs, and they actually have a better risk profile than other docs. Indigent population. It's been mentioned in the past that, oh, indigent populations tend to sue more. I don't know, maybe they see an opportunity. That's not the case. They don't tend to do that. Negligence. It does not necessarily correlate with a claim. It sounds crazy, doesn't it? But the interesting thing is, the patients are not qualified to judge the medical care that we all provide. They are qualified to judge the experience that they had. And our system is flawed right now because if somebody has a problem or doesn't feel they were treated effectively or appropriately, or you just made them mad, they can do one of two things. They can write a letter to the hospital. If that doesn't work, they can sue you. There's nothing in between, really. So this is their way to get their day in court, literally and figuratively. And if you don't provide the best practice, the best possible care out there, that's not really what formulates a lawsuit. Best practice is what we all need to be shooting for, but standard of care that we'll talk about is what you need to meet for, to make sure that you're not at risk for a suit or at least have a good defense for one. So what does correlate with claims? If you're not nice to people, if you're a grumpy provider, grumpy nurse, grumpy doc, and you're at risk for a claim. And I'll tell you, from a patient satisfaction standpoint, your best tool if you're a grumpy provider is very short throughput times and spend as little time with the patient as possible. If you're not a nice person, don't be forcing it. You know, I spent more time with those patients and I keep getting ones on my Press-Ganey surveys. You think? I mean, absolutely. You're grumpy. Get away from the patients. Have somebody else go in for you. Wave at them. Whatever you want to do, but don't spend time with them, for God's sake. If you're not fast, if you're slow, everybody under your care is in the department for 6 hours, there's a lot of service recovery that has to go on there. You got to be extra nice to make up for that because people don't want to stay there with us. They want to go home. If you don't read, meaning you're not keeping up on your skills. The doc or the nurse that says, you know, I was the best that I ever was when I finished medical school or nursing school, that's a scary concept, and that's not the person you want taking care of you, your family, or your patients. The box checkers, we talked about them already. No humility. You know, I know I'm right. This is your diagnosis, and go on home. Nothing else could possibly be happening with you. Families and patients will hold you to that standard if you want to act like you can't make any mistakes. But we should always understand that an emergency department visit is a snapshot in time. And we don't oftentimes have the ability to make a diagnosis while they're in the emergency department, so why give them one? We've gotten to the point where we don't have diagnosis listed on any chart. It's a preliminary diagnosis or it's a impression, but we're not implying to them they're getting a final product, and that's what a diagnosis is. I can tell you what I think you have now, and here's why I think that, but here are the other possibilities, so over the next 24 hours, this is what I want you to watch for. But based on this point in time, this is what I think you have. But it's not a final product. You would be surprised how powerful that one statement is with a malpractice claim. We never told them that was their diagnosis. You know, you tell somebody they have a diagnosis of costochondritis, they go home and have a PE. Well, you were absolutely convinced they had costochondritis. That was your diagnosis, doctor. So don't use the term. If you don't listen, you're going to run into trouble because you'll miss key elements of the history. You really will. If you're a poor documenter, I can guarantee, I don't like to ask personal questions on this, but does anyone in this room know anybody that's been involved in a malpractice lawsuit? Do you know anyone who has? Okay, people are tired, I get it. Okay, we'll move this thing along. But the key is, everyone probably in this room has had a chart go to a plaintiff's attorney. Those who document their care well and explain what their thought process was, you never hear another word about it. And why is that? And honestly, this may sound horrible, but why does a plaintiff's attorney decide to take a case? One reason. To right the wrongs in the world? Is that it? Do you really think? What's the reason? Money. Absolutely. If there is a financial win for them at the end of this thing, for the patient and for them, yeah, they'll take the case. And quite honestly, look at a well-documented chart, They might even run it by an expert witness and say, hey, take a look at this, let me know what you think. No, it looks great. That case is done. So probably everybody in this room doesn't know it, but we've all had our charts read by a plaintiff's attorney. Bad outcomes. Bad outcomes happen to sick people, and we see the sickest of the sick. So bad outcomes don't necessarily correlate. They can correlate with claims, but it doesn't mean that just because there's a bad outcome, you did something wrong. But when people have bad outcomes, oftentimes they want an answer, and they want someone to be responsible for it. Unless we tell them up front, I may not have the right answer for you, but based on the information I have right now, this is what I think is happening with you. So make sure you have some humility. If you practice below the standard of care, then believe me, and I'll tell you, that's not a very high standard, you are really at risk for a claim. It's not a high standard at all. Okay, negligence. Interestingly enough, looking at this data, negligent adverse events. Southern Medical Journal 2005, only 37% of paid claims were based on negligence as the cause of action. Interesting. Over 49,000 primary care claims between the years of 1985 and 2000. Only 23% were based on negligence. 68%, however, were in outpatient settings, were considered an outpatient setting. This was looking at primary care claims, but it does let you know demographically we're at greater risk. Our patients are sicker. We don't have relationships with them that are ongoing. And a lot of suits come, a lot of malpractice issues come from outpatients. All right. Negligence, what causes negligence? And what equates to negligence in a lot of suits? Errors in diagnosis, 39% of the time. Delays in management. If you've got to get somebody to the cath lab, you got to get them there quickly. Improper performance of procedures. You don't know how to do one correctly, or you have a bad outcome with it. Complications from procedures. Failure to monitor care, and the big one is communication. Patients want to be communicated with, and you can avert a lot of problems without spending any money by updating patients, letting them know about wait times, letting them know what to expect about their care, and letting them know, it's amazing to me too, that we don't have this conversation more with our patients. Do you think, I'll just ask you guys, do you think, let's use the CBC as a good example. Is the CBC a bad test, a good test, or a great test? In general, for looking for anything, a CBC. Does it tell us that we have any particular problem? Is it sensitive or specific for anything? No. How often do we tell our patients, hey, you know what, for this problem, we have some pretty good tests, but we don't have any great tests. Our tests have limitations. So what we've done today is the best I can provide for you. We still don't have great tests to find out what's happening with you. And you have to let them know that the tests aren't perfect. Communicate with them, it's key. Pain medication delays. We know too that from a patient satisfaction standpoint, patients want to be treated effectively for their pain as well as quickly for their pain. Anyone have any objection to treating kidney stone pain as fast as possible? Would we all agree that kidney stone patients, generally speaking, are not inappropriately drug seeking? We look at them, we're like, we've got to get them analgesics right away. We're all good with that? 2 head nods. Even the swabbing lady is almost done today. She's like, okay. So, but seriously, we got to get pain medicines too. And we looked at our departments, several departments a couple of years ago, just taking a look at this one metric. And how long did it take from the point of entry to the time medications were actually delivered? The best department was like 25 minutes. But the department thought they did great because by the time the order was written and the nurse was ready to go, it seemed like the patient got the meds right away. But what about those non-value added steps ahead of time? We had one department that was 120 minutes. And they thought they were delivering pain medicines quickly. That's unacceptable. And if patients aren't happy, then they're going to be more likely to sue you if there's a bad outcome. Admissions and boarding, those cause delays. Door-to-doc time. Patients want to see the physician, want to get to the nurse as soon as possible, and want to get through the process that actually adds value. And they want to get to the bed and get things taken care of. And door-to-decision time and overall length of stay are really critical to making people happy. Again, you can be kind of grumpy, but if you get people out pretty quickly, they're relatively happy. They really are. Delays on top of delays equal poor patient satisfaction. It's really important to remember that. And what really affects patient satisfaction is important. What are the 2 critical factors, if you look at all the current literature that's out there right now, that impacts patient satisfaction? Anybody? Somebody? Okay. All right, I'll tell them to you. Well, you don't have to. You're kind of running the course, so we'll exempt you out of here. But really what's interesting, do you think wait times are a factor? They are a factor, but it's kind of a loaded question because if you look at the data that's out there, it's actually perceived wait times. What do we do with their time? You can actually, it's actually been studied, if you change something operationally and shorten the length of time versus just change the perception of length of stay and their time, the perceived reduction in length of stay is actually more effective with patient satisfaction, actually reducing their length of stay. So we've got to do things with them to make it better. And the other is the quality of the interpersonal communications with their providers. It's those two things. You've got to be nice to the people. You've got to do a few reasonable things to show that you care. Again, they're not qualified to judge the medical care that we provide, but they are qualified to judge if you tried, if you were nice, if you genuinely cared about them or not. Okay, standard of care, quickly. What a reasonable physician or provider, depending who that would be, with similar training would do in a similar circumstance. So if it's not a huge standard, it's not hard to meet that standard, quite honestly. It's not best practice. Best practices are irrefutable evidence supporting one treatment plan. It's the consensus. We all agree that there's one way to do things. We all agree in acute coronary syndrome, you need a minimum of 162 milligrams of aspirin. You can go higher if you want, but the standard of care is the minimum standard that you need to provide is giving them aspirin. If you don't give them aspirin, you've not met the standard of care, because we know, back to ISIS 2, several years ago, that was absolutely probably the biggest bang for our buck with acute coronary syndrome we were ever going to get. So we all agree on that. So that is a best practice, and a best practice that actually becomes the standard of care. And when we know that you have a best practice that you need to incorporate into practice and you don't, you're kind of practicing the art of medicine. And the art of medicine is really when we don't have irrefutable evidence. We're not really sure, we don't have consensus on what the right thing is to do for a certain disease entity or problem. So one person can treat it one way, another person can treat it another, and that's the art of medicine. But when we have a best practice established, you can't start throwing paint on a canvas anymore. You can't do that. You've got to make sure that you have addressed that best practice and incorporated that into your practice style. Okay, clinical issues. I've listed several things here that if you put these things in your mind, these are where the hot topics are right now in emergency medicine with misses. And so if you program these into your mind and know, if my patient could have any one of these things, I need to step back for a moment. I need to step back and decide, is this a compartment syndrome case? Could I miss it? Is this an MI with an unusual presentation? Lots of different things here, but you need to keep these in your mind. This is what we're seeing, and here's the top 5 list that we're seeing right now with our risk retention group. Acute coronary syndrome, always. Those are huge. Many varied presentations at this point, and it makes it ripe to miss a case of acute coronary syndrome. Ectopic pregnancies. Anybody seen an ectopic pregnancy in the last month? In the last week? They're always hands. And it's becoming more and more frequent, and this is a life-threatening disease. Stroke and TIA, Cauda equina syndrome, appendicitis, and we'll talk about all of these. Okay, first thing, acute coronary syndrome. Incidence 234 per 100,000, so it's pretty common. Misdiagnosis rate for MI is 4.6% based on this article, 6.4% for unstable angina. We are missing these despite all the stuff we're doing and all of the admissions that we're providing to the system when patients or when our medical staff members think we're admitting too many. We're still missing them, okay? Contributing factors to risk with acute coronary syndrome. Missed triage. If you look at the data that's out there from that article, 50% of the misses are due to missed triage. We're sending them to the wrong place because we're just not picking up on the right information at the first point of contact. Misapplication of data. They got normal enzymes, and they got normal EKGs, so let's send you home. So are EKGs good tests or great tests for acute coronary syndrome? At best, they're good tests, and they're not great tests for sure. So if you were deciding who's going to stay and who's going to go based on a normal ECG, that's a problem. And if you're not really incorporating the concept into your decision making about nonspecific changes being important, you can miss things too. Patients with nonspecific changes on their EKGs, up to 23% of them have underlying coronary artery disease. We don't know if that coronary artery disease is causing their symptoms or not, but they have it, so almost a quarter of them. So when you write nonspecific changes in your interpretation, that's not a benign thing to write. And then there's so many variable presentations that can happen too. We can miss these because we don't realize that the person with arm numbness or arm tingling or arm pain or with shortness of breath or fatigue might be somebody who has acute coronary syndrome. So what are the solutions? Appropriate risk stratification, risk factor assessment, disposition not impacted by enzymes. You know, there are many departments out there, I think maybe most departments, after you get a few sets of enzymes, you feel comfortable sending somebody home. Anybody have a protocol or a practice pattern in your department that after a couple sets of enzymes, you get sent home for outpatient workup? Yeah, there's always a few hands. My question for the people who raise their hands, and you don't have to actually answer, it's just a rhetorical question, is what are you ruling out? I think if you've had pain for 6 hours, there's pretty good data to say even 1 troponins probably ruled out an MI, if you know when the symptoms started. But I think you can have 3 troponins, 5 troponins, 20 troponins, 45 troponins, and what have we not ruled out? Unstable angina. So you are likely to send your unstable angina patients home. You saw the data, much more likely to misdiagnose people with unstable angina. This is one of the reasons. You get multiple sets of enzymes, multiple ECGs. For unstable angina, neither are great tests. Actually, the enzymes are poor tests, and we send them home based on that. Yeah? Okay, well let me consider that. So you said it's not excluding the diagnosis, but you're trying to decide if it's safe to send them home. So what you're saying, it's a risk stratification tool. But, you know, and I would just take that one step further. Who's safe to send home would be those people who you don't think are at risk, who don't have ongoing unstable angina or acute coronary syndrome now. The enzyme doesn't really give you that answer for unstable angina. So you just have to be careful with that. And I understand too, if you're in a low risk category or an ultra low risk category, you can incorporate many decision factors to put yourself or your patient into that low risk category. And maybe some of those patients are safe to go home, particularly under the age of 40. But if you're basing your decision, which a lot of people do, well, they got 2 sets of enzymes and they've had 2 normal EKGs, I can send them home. That's flawed decision making, it really is. And if you look at the data, what's very interesting is you look at the curve right at age 40. Under age 40, very unlikely for your symptoms to be caused by acute coronary syndrome. Not impossible at all, but you're a lot safer at that point, and those are a lot of the patients that end up in the ultra low risk category. Okay, so again, follow national standards of care. So what do we have? ACEP drafted a clinical guideline a while ago, a couple of years ago, and they said level B recommendation, which is pretty strong evidence, that you should perform repeat ECGs, and you should do them roughly within 30 to 60 minutes if somebody comes in with a presentation that concerns you for acute coronary syndrome. So what's the solution based on this? What should we be doing as far as guidelines go or protocols go? Not only is this a best practice, but as soon as ACEP published this clinical guideline, when your specialty society publishes a guideline, it automatically becomes the standard of care. So now you've got a standard of care, this is what you should be doing. So we need to obtain the initial ECG within 10 minutes. We know that's been around for a while. Repeat ECGs within 30 to 60, and I'd recommend too having a policy in place where you just automatically hand the doc the old ECG if it's available. Make them compare it. Don't wait till they ask for it. You might miss a subtle change. It's very important. Okay, missed ectopics. Incidence amazing, as high as 1 in 40 pregnancies at this point. They are so common and they are so life-threatening, we have to be very careful. Misdiagnosis rate up to 40%, we're getting this wrong, 40% of the time. Contributing factors to risk here, not ordering a pregnancy test. Can you imagine, in the right people? You know, we have a policy in place that from ages 10 to 60, if you're capable of becoming pregnant, and you have abdominal pain or vaginal bleeding or both, you're having a really bad day, you get a pregnancy test. If not, you call our on-call physician who handles these policies. We rotate that responsibility. You call that person and you say, you know, I don't think we need to order a $2 test. I don't think we need to get urine from this patient, and this is why. For the most part, these calls aren't made for this policy, but I have received a few of them. I don't think we need to do it on this patient because I'm not concerned about ectopic. And it's very indefensible when you miss an ectopic and all you needed was some golden urine to find the right answer. Okay? Not ordering the ultrasound when you do have a positive pregnancy test. You've got to make sure it's not an ectopic. Don't use discriminatory zones. How many of your OBGYN departments or radiology departments want to tell you you can't get an ultrasound because the patient's quant is below 1,000 or 2,000 or 1,500, whatever article they read? Anybody? It's happening all over the place for us. And the scary thing is, if you look at the history on discriminatory zones, they were designed to tell people when you're likely to see an intrauterine pregnancy. That makes sense. So when your discriminatory zone is 1,000, if you believe that article, or 1,500 or 2,000, you should see an intrauterine pregnancy. Where in the literature does it say that you won't see an ectopic pregnancy or suggestive findings for an ectopic pregnancy if it's under that? It's nowhere in the literature. They're misquoting the literature and forcing us to do something that's unsafe for our patients. Don't use discriminatory zones to decide who you're going to do an ultrasound on who has a positive pregnancy test in which you're worried for an ectopic. They have a high mortality rate, so when we do miss them, they go home and they rupture, they become hemodynamically unstable, and they're young, healthy people otherwise, usually, and that is ripe for a claim or malpractice lawsuit. So what are the solutions? all childbearing age females with abdominal pain or vaginal bleeding are tested if they're capable of being pregnant. We have that one caveat there. If you've had a hysterectomy, we tend to not force our docs to consider the possibility of pregnancy test. If they've, have not started their menses yet, okay, fine, then maybe they can't be pregnant, but, then we've got to make sure that we cast a wide net so we don't let any ectopic slip through. All right, standing orders, and we'll talk about that, and ultrasound standards. Who's getting an ultrasound, anyone that we're considering ectopic with, and what are we looking for? What are we looking for on that ultrasound, and who's reading it and giving us the right answers? We'll discuss that as well. Okay, this is just a graph from 2006 from our departments. We were having a problem with this policy not being complied with. We were doing chart audits and realizing, for whatever reason, pregnancy tests were not being ordered. They just weren't. I mean, one doc told me, it was actually one of our directors at the time, and he said, I didn't need to order it on this particular case because this person, this lady was 21, she was in the military, and she did 50 sit-ups the day before. That's why she had abdominal pain. Like, wow, I think that maybe you had premature closure of your differential here, and I don't think, perhaps maybe in the military they do sit-ups on a regular basis. Why today? Why is she sore today? And again, urine isn't hard to get. Most patients throw it away readily. So we can get it. It doesn't cost anything, and a pregnancy test is cheap. Same test they would order or get right off of the shelf in a pharmacy. And how do you explain that to a plaintiff's attorney when they have you explain that to a jury as well, that it was really something I didn't have the time or the inclination to do? It's not hard. It's not expensive. It takes a little bit of thought. So what we did here, if you look at this site over on the left side, they missed 40 in 1 month. They were applicable and they should have the pregnancy test. What they did is they put a standing order in place so that the doctors were not practicing the art of medicine on this decision. We know this is the right thing to do. This is irrefutable. So why are we using our mental power, our brain power, deciding, I wonder if I'll get a pregnancy test on this one. Let's decide if we're going to deliver TPA and stroke. Let's decide if a patient needs a CT pulmonary angiogram or do they not need a CT pulmonary angiogram. That's what the doc should be thinking about, not whether or not we should get a pregnancy test. So now at that site, it's done at triage if they meet the criterion, and the doc is removed from the decision making because we don't need the doc's input at this point. And that site has gone to 0 and since that time has not missed one. And that's probably the way to go. All right. As far as bedside ultrasound goes, if you take a look at this case, it's kind of interesting. It's kind of scary. This is the second visit. I'll give you the second visit right up front. Dr. So-and-so saw this patient, performed a bedside ultrasound showing free fluid in the belly around the liver. He has spoken with the physician on call. The patient is to be kept NPO to go to the operating room. Diagnosis, ectopic pregnancy. No surprises until you see the first visit. Now take a look at the other diagnoses that are listed here. Pregnancy and ruptured ovarian cyst. Once you've got your ectopic pregnancy, why do you care if there's a ruptured ovarian cyst? Do you? Doesn't that sound kind of strange? Usually if we've got the slam dunk, it's like, oh, ectopic. I don't start listing, history of gestational diabetes and history of, you've got the slam dunk diagnosis, the important one. Well, here's why. Same doc saw this patient on both visits. And here was the ultrasound on this doc's own interpretation. This site did their own ultrasound, did not have any radiology oversight. They did their own interpretation, had their own credentialing. The hospital let them do whatever they want. She had an emergent ultrasound transvaginal which showed a normal uterus, normal right ovary, and a small 1.4 centimeter cyst in the left with an itty-bitty heartbeat that nobody saw, perhaps, maybe. There is moderate amount of fluid in the cul-de-sac surrounding the left adnexa as well. So are we misinterpreting results here? You got somebody with a positive pregnancy test, pain on that side, and instead of going with, hey, I've got fluid, it's probably ruptured ectopic, oh, we've got a cyst. Here's the rest of the information from that doc. She had minimal tenderness, cannot exclude ectopic at this time, but this doesn't make sense either because if you can't exclude it, why are you sending her home? She needs seroquantitative HCGs and ultrasounds. I think she probably ruptured a corpus luteal cyst or a previous ovarian cyst, and the fluid is probably secondary to that. She has no evidence of hemodynamic instability. At this time, I think she can be safely discharged. Do you agree with that disposition and that line of thinking? Can any ectopics be sent home safely? Those that were suspicious of ectopic, but we haven't removed it from the differential because we don't have an IUP, but we don't have definitive diagnosis or confirmation of ectopic. Can we send some of those home to the OB/GYN the next morning? Yes, we can. We can do some of those. Again, flawed logic. If you have free fluid, what type of ectopic is it if you have one? It's a ruptured ectopic. Generally, we try not to send those home. Those are the ones that get sicker and have hemodynamic compromise and bad outcomes. So what do we need to do here? We need to make sure that there are good standards in credentialing and in training and in oversight. Let's make sure that radiology reviews the doc's competency, or maybe even reviews every ultrasound in the morning to make sure there are no misses. So there was a big change there. All right, stroke and TIA. Okay, incidence, 1 in 453. 750,000 strokes in the U.S. Each year. There's a lot of them. And that's why it's a big concern for us too. They're devastating and there are a lot of them. Misdiagnosis rate, 14% in the age less than 50 years. We're missing a lot of these. We're saying, you know, your symptoms just don't sound like a stroke. And what's amazing, TIA symptoms last on the average how long? 5 to 10 minutes max. So what are the chances of them having their symptoms while we're there with them? If they had their symptoms while in the last 5 to 10 minutes, they had to be there for something else first, right? It doesn't take them 2 minutes to get to the ED, usually. So what happens is they tell us what they experienced, and we go, well, you look fine now. And maybe did you really have difficulty with your speech? I don't know. We discount it, and they get, and sometimes end up getting sent home, which isn't right. Contributing factors to risk here. 33% result in death, a third of these. If we miss them, bad things happen. Even when we don't miss them, bad things happen. 200,000 a year are disabled. Again, they have varied presentations. So many vascular distributions that we miss, and we say there's no way that this could possibly be a stroke. It can't be sensory alone. Can you have a sensory alone stroke? Yes, you can. That's one of the 5 lacunar infarct syndromes. Absolutely. But if we don't realize that, we can discount it and miss it. How about fibrinolytic issues, thrombolytic issues? I like to refer to this as litigation. If you don't give thrombolytics and someone thinks it was appropriate to do so, what happens? You get sued for not giving it. You give thrombolytics and they get a bleed in their head, which is fairly likely. Then what happens then? You're sued because you gave it. You get sued coming and going with thrombolytics. And TIAs are not taken seriously. TIAs are really the equivalent of unstable angina of the brain. We need to be thinking in that way. We don't want to send unstable angina patients home, but TIA patients, it goes down to the core of how we were trained. Oh, you had a mini stroke. It's not a mini stroke. You're about to have the big one if you go home. But we're calling them mini strokes and TIAs, and they're very, very important. Solutions. We need policies about lytics. How many of your sites do not deliver thrombolytics? You just don't have the resources. Don't want to do it, can't do it, whatever the reason is. Make sure you have a policy. If it comes up later, well, we think they were within the three-hour window, or 4.5 if you like ECAS 3, or whatever you're looking at, and we think this patient should have had it. All you have to say is, I followed my hospital policy. Now, if someone wants to challenge the hospital policy, the hospital's the one who's going to have to answer to that. You followed it, you're fine. But if it was an individual decision and you just decided not to, you'll be on your own with that. Admit all new onset TIAs. Someone who's never had TIA symptoms before and it's new, and you do not have a structured, already established outpatient plan to work these people up quicker than they could get in the hospital, you just put them in the hospital. And here's why. One of the best articles out there, JAM of 2000. This should have changed our practice, and today it still has not done that. They looked at patients who were diagnosed with a TIA and were discharged from the ED. At 90 days, 10.5% returned with a stroke. 50% of those that returned did it within the first 48 hours with their stroke. So are TIAs safe to send home? A new onset they've never had before? They really are not safe to send home. And here are the predictive factors of those that will return quickly with their stroke. Age greater than 60, if they had speech problems with their TIA, weakness, diabetes, or their symptoms lasted greater than 10 minutes. Especially any of those, we need to keep these people. And yes?
Not just ask, is this based on new intervention or possible intervention like aspirin?
Sorry, I didn't hear the first part of your question.
Is this study based on patients that were discharged with zero intervention, that is, no aspirin or anything?
Good question. He asked if the study was based on patients who were discharged with no intervention or interventions like aspirin put in place, those type of things, all comers. If they had aspirin, fine, they were lumped in there. If they didn't have intervention, they were lumped in there as well. It was just looking at the demographics of TIA patients, new onset, who were sent home, what happens to them in disposition and outcomes. And that should be fairly compelling evidence to us, and this has been supported in other articles since then. Yes?
And what if they've had a carotid Doppler study, an echo, a CT scan, and they're put on either aspirin or Plavix? What are you doing differently to keep them in other than
That's a good point. So basically what you're saying is if they've already had an adequate workup as an outpatient, then you're probably fine. But have they had it for these symptoms? Something could have changed. Now, if the patient's had the symptoms, they've had the workup, you can make the argument that, yeah, they've already had it. The reason we like this from a risk management standpoint is if you look in the literature, there's no standard of what that workup should be. There is no standard that it should be this test plus this test, and that's the end. When they get admitted, they get all kinds of different tests. And once you do admit somebody, then you've done all you can to make sure that the person had as much access as possible to the healthcare system. But I do support what you're saying. It's a reasonable decision that if you've had the workup you're going to get in the hospital anyway, just send them home with close follow-up. That's probably fine. The error that I see made all the time is a diagnosis of TIA going on the chart, and maybe they want to send them home because they've had a workup. The patient still has symptoms. It's not a TIA until their symptoms go away in under 24 hours, right? If you still have symptoms, you can't go home. You can't call it a TIA. So make sure that mistake isn't made. All right, Cauda equina syndrome. Anyone seen one of these recently? Okay, you've seen one. So was that last month? You know what's amazing? Amazing. 3.4 per million is the incidence. How common is that? It is so uncommon. But look how many hands went up here. At least 3, 4, maybe 5 hands went up. So we know that we're selecting out a subset of patients that have this disease that other people aren't seeing first, and we're missing it. And we're missing it bad. We've had a string of probably 5 cases that haven't really resulted in a claim or litigation, but we've been concerned about that had bad outcomes due to missed Cauda equina. It's always multiple visits. The miss rate, we don't know what the miss rate is because it's so infrequent. We don't know, but we know that our personal experience is the docs are just not thinking about this. And what are the contributing factors? Who gets Cauda equina syndrome? Somebody who was normal, never had back pain in their life and comes in and now has back pain? No, it's the chronic back pain person. Are you kind of figuring out why we're missing it now? As soon as they come in, oh, Joe's back with his back pain. Just wait, he's going to ask for 2 Dilaudid, guaranteed. He's allergic to Motrin, Ultram, morphine, Demerol, anything else that you can think of that you want to give them other than 2 Dilaudid. The problem is, it's these chronic back pain patients that ultimately will have a decompensation and develop Cauda equina syndrome. You have to ask them if they have new symptoms. And there can be very subtle symptoms such as sexual dysfunction that they may not share with the triage nurse. So why are you here today? I got my back pain, and oh, I had this episode last night. I mean, are you sure they're going to tell you that? I don't think they will. So you've got to ask for these things. Low incidence, doesn't happen as often, and that's why we're not thinking about it. And MRI availability. MRI is the right test. How many of us can get it at 2 o'clock in the morning? Not that many. But if you're worried about this diagnosis, you've got to arrange it for the next morning. You've got to transfer them somewhere where they can get it. Make sure you close the loop on this. So what are the solutions? Perhaps all back pain patients get a standard exam, and you can follow this with chart audit. There should be sensory, motory, reflexes, and gait tested. Make sure there's not a new change. Hey, you know what? You seem like you're dragging your foot a little bit. Have you always had that with your back pain? No, that's new. I didn't even notice it till you examined me. You know, if you find something that's new, you've got to assume that there may be early Cauda equina syndrome. Another issue with Cauda equina is interesting. A lot of people are misinformed and think that urinary incontinence is associated with Cauda equina. It's actually not the case. It's urinary retention. You can't relax that sphincter. When you do get a little dribbling of urine, that's because you have overflow incontinence because you stretch the sphincter. And that's when you get a little bit of urinary incontinence. Okay, so let's make sure they have a standard examination, document discussion about new neural symptoms. The patient reports no new neural symptoms. Diagnostic evaluation when discovered, it's got to be emergent or urgent based on you talking to whoever you need to on the phone. If you're not going to get the MRI emergently, then talk to the neurosurgeon and say, do you want me to get him scheduled for it in the morning and send him to the office? I mean, you can close the loop and not get it immediately, but you can't say you don't have Cauda equina syndrome. Okay, the other issue with this as well, this one didn't come up the way I expected it to, but let's talk about appendicitis, okay? First of all, we'll start with this first topic. Does anyone know what this is? Somebody gets the last cookie that's up there if you get this. I have no idea. I have no idea. I didn't take the picture, but great question. I wish I could answer it. New Zealand, I think. No, wow. You have definitely outclassed me on that one. So, yeah, it's a nighthawk. And absolutely. Oh, do we have the pointer? No, take a look at this. Yeah, what is the night? What do you see that's classic for the nighthawk? Freaking eyes are closed. So what happens when their eyes are closed? They miss things. So have any of you gotten a call in the morning where Nighthawk read a CT of the abdomen the night before, it was no appendicitis. Your doc comes in the morning, your radiologist, reads it as appendicitis, you have to call the patient back. We've probably had 50 of those in the last 2 years. It happens at every one of our sites with varying frequencies, but we know that they just are not reading with the same quality as our docs do at our radiology departments. For whatever reason, our radiology departments value their sleep better than the quality of the care provided from their department. They're willing to live with the poor quality overnight. It's disappointing, but that's the case because we're just seeing far too much of this. What else do we run into with appendicitis? Reliance on a normal study. Even if everyone agrees the CAT scan is normal, is it a good test or a great test for appendicitis? It's a good test, but it is not a great test. And you need to tell your patients, just because you had a normal CAT scan, even if we see the appendix, you're less likely to have appendicitis, but it's still in the differential. I'm not removing this from the differential. But within the next 12 to 24 hours, things are going to get a lot worse if you have it. Here's what I want you to do. That makes the difference between you being the doc that said, wow, even the CAT scan was normal, and this doc said I could still have it. They were really smart. Or this nurse told me, when I went home, I could still have this diagnosis, and they were super smart. As opposed to them going to the other hospital and the other doc saying, well, you got a fever of 103, you can't walk, you got a white count of 25,000, it's appendicitis, I don't know how they missed it last night. That happens everywhere. And you've got to make sure that we don't do that to our colleagues too. Of course it's easy when we see it the second time. The first visit, it's easily missed. And make sure they know the limitations of the test. Okay, top 5 operational issues. The triage process, the intake process. Make sure they're not waiting too long and make sure that we understand how to get them into the system quickly. Can we get a provider out front? Yes. Boarding is an issue. Handoffs, radiology discrepancies, and consent. We'll go over a few of these concepts and we will be done. Okay, so physician and triage. Decrease, when we had our experience, we decreased our left without being treated, as I mentioned, substantially. We decreased our length of stay substantially. Improved patient satisfaction at this one department by 66 percentile points in 1 month. It was amazing what happened. Improved staff satisfaction by 100%. They first said, I don't think we want to do this. Who wants to hang out with a doctor all shift, right? I mean, God, it's bad enough we have to interact with them for a few minutes when they're in and out of the room. Actually, the staff likes it because the patients are happier, the patients are out of there, 30% of them are discharged right up front, never need a bed in the back. Okay, waiting room issues. Who's responsible for the waiting room? The person who owns the hospital. And that's the hospital. They own their own waiting room, the hospital board owns it, and their employees out there, unless the physicians are employees too, but usually it's the nurses who are responsible for the waiting room. And so we've got to make sure that we're being careful with that. Does anyone remember this issue with the lady last year, I think it was last July? I went down in the psych waiting room, but still it was a psych emergency department. All the news flashes were it was an emergency department death. Do you know what this lady died from ultimately? It's PE, exactly. So this lady drops, everyone kind of steps, so they mop around her. The only place that isn't nice and clean and waxed is the place where she's like this on the floor. And so her family says, what a horrible thing. My sister was killed twice, so great, now we're going to get 2 claims on this thing. This is what her sister said. First, by those who neglected to offer her the needed health care, her needed health care. Secondly, she was killed by those who tried to cover up this criminal action. Now, I don't know where the criminal end of things went or even where the medical malpractice went at this point, but the scary part is there's about 4 or 5 cases in the U.S. in the last couple of years where they're considering filing criminal charges because no one has provided the right care. Okay, boarding. We'll talk about this quickly. Who has the responsibility for a boarded patient in the ED? Anyone? Yeah. The ED team. Just because they're admitted does not mean that you now don't have responsibility. You're the care team that's immediately available. No one wants to hear, oh, well, they should have called upstairs to get orders from the other doc, or the other nurses should have come down and take care of this person. It doesn't work. Admission orders, who should write admission orders? Ideally, the person admitting the patient. So if the patient's going to go upstairs, I know it's a nice service that we can provide, and there's some controversy here, but I'm going to tell you there's some risk associated with this. What we are doing by writing admission orders, beyond just a holding order, send to the floor, here's the diagnosis, call Dr. So-and-so upon arrival for orders, that's okay. But if you're writing for TED hose and continue the nitro drip and here get them an 1888 diet, what that is saying is you're accepting care for that patient on the floor. And we're enabling our medical staff member to go do something else, like stay in bed, go see him in the morning. Did we tell them we had to complicate their lives by practicing internal medicine? Bad choice, but it wasn't our choice, it was theirs. So they need to be accountable and come see their patients. If there's a bad outcome between the time they accept responsibility by either calling in orders or seeing the patient and the time you've written those orders, who's responsible? I will guarantee it, it's you. And a good plaintiff's attorney will ask you one question and the case will be over. So doctor, when were you going to go check your patient up on the floor? And your response is, I don't even know where the freaking floor is. I don't go there. I was never going up there. And that will not fly. I won't read this whole thing for you, but basically, this is directly from CMS. It says that the hospital's EMTALA obligation pretty much ends when the decision to admit has been made. So EMTALA is taken care of, but they also say the hospital has to have a policy to clearly delineate which practitioners are responsible for writing admission orders. They understand there's a problem here too. And there's also some real risks, so be careful with that. Patient handoffs, 20 to 24% of malpractice claims are associated with a bad handoff. We always have known it's been a high-risk time. We know more so now than ever that it's a real issue. Good example, I have a few cases for you. A 24-year-old male patient, he's waiting for a ride. This is actually a case I had. Came in the morning, came to 7 o'clock shift, the night doc said, this guy's been drinking all night. You've had this case, right? Drinking all night, he's sleeping it off, the family's going to come get him. They should be here at about 9. So go check on the guy, call the family, actually have them come in earlier. Last thing I want is him sleeping there all day. If I can wake him up and he can be drunk at home, wouldn't you be happier being drunk at home? What, you have friends there. You don't have friends here. Go home. So I try to wake him up. I call the family. He does not look right. On the monitor, he's got a heart rate of 130. It's like a Glasgow of like 11. Something is not right. And I asked the family, and they said, oh, he took Tylenol PM last night. So what we thought was an intoxicated patient just waiting, and the handoff was inadequate. Oh, they're just waiting for a ride. You don't have to do anything. Discharge instructions are up on the rack. So when the mom gets here, just send him. He's got the actual Glasgow was 7, heart rate of 132, respiratory rate of 12. He gets intubated and goes to the ICU for anticholinergic toxicity for this diphenhydramine overdose. Handoffs are important. When you're at the end of your shift, you're going to make mistakes. And hand it off to somebody who's at the beginning of their shift when they're fresh, and they're going to hopefully help you miss a mistake. So what are the solutions? Limit handoffs. Less handoffs, the better. Write a policy on how we're going to do handoffs. Mandatory assessment by the incoming physician. It may sound painful, or the incoming nurse also. When you take over a patient, unless you feel you have no skills and nothing to provide in the equation, you should go see the patient and see if you want to change something. Document that reassessment. This is what I found. The final physician carries the majority of the burden. It is so true. If you've been with the patient for 4 hours, you turn it over to somebody else and they discharge them after 30 minutes worth of care and there's a bad outcome, who is going to be the one that's likely going to carry most of the burden? It's going to be the one who wrote the discharge order. Even though you spent 4 hours with the person and told them, when the potassium's done infusing, you can send them home. Great. Well, that sounds like a great idea. What are they here for? You've got to ask these questions and be careful. Consent. I think consent, and we're almost done here. Informed consent is very important. We've got to talk to the patients about the risks and the benefits. The risks and the benefits of treatment versus non-treatment and treatment alternatives. And also, anyone here doing any research? Any research, academic institutions? Okay, at least one person. If you have an interest, a conflict of interest, actually, it can't be an informed consent unless you disclose that conflict as well. So you've got to do that. Probably more important than that is informed refusal. Informed refusal is under the same doctrine of informed consent. With AMAs and procedures that patients don't want, we still have to inform them the risks and benefits of treatment or not treatment and alternatives. And then with certain things, we want them to clearly state to us they don't want the procedure and sometimes even sign. If somebody declines TPA after you explain it to them, and I know for whatever reason, I'm not a TPA proponent, they never accept it from me, but I do offer it when it's applicable. I give them my spin on it and they don't want it. Well, I have them sign that they understood it and they don't want it. And I can say later, they had an informed refusal. I mentioned the treatment, we discussed it, they don't want it, and that is very powerful. And again, the standard of care for informed consent and informed refusal is what a reasonable physician would have anticipated that the average patient would want to know. You're not expected to know what this particular patient wanted to know. So what the average patient should know about an LP, you need to explain. You could have infection, you could have bleeding, you might have a little pain down the leg temporarily, but it shouldn't happen. And you know what, you might get a headache from this thing, but you've already got a headache, so don't worry about it. They always laugh, even if they have a headache, they always laugh when you say that. All right, so this standard applies, and you have to decide whether you want it written and signed or just dictated. You know, with a lot of consent forms, or particularly AMA refusals, you can create a wedge between you and the patient by forcing them to sign a refusal. If you document it well in the medical record, that's very powerful and that's adequate. Okay, a couple cases here with informed refusal, and I want you to tell me if you think this is adequate informed refusal. 47-year-old male presents with neck pain and headache. CT of the brain is performed, it's negative. He is offered an LP by the emergency physician to rule out meningitis. And the physician stated, this is out of their record, I doubt you have meningitis, but if we want to be certain, we have to do a spinal tap. A spinal tap. If you use the word spinal tap, guaranteed they will not want it. If you describe it based on Linda Blair's experience in The Exorcist, they will not want it. So you can tell them it's a fairly benign procedure. It's safer than an IV start, and it's true. More complications with IV starts than with LPs. But anyway, do you think this was an informed refusal? Okay. Well, we're going to find out why here in a minute, but we'll talk about this next case in a moment. I actually saw the patient on the second visit. I didn't need to do the LP because he came in with a Hunt and Hess class 4 subarachnoid hemorrhage. Actually, the guy did great. I don't know how he did great. Got intubated, got flown out, craniotomy. I've actually seen him a couple times afterwards, completely neurologically intact. What's interesting is he has no idea what he had on the other end of the first visit, because he did not have an informed refusal because they didn't tell him, oh, by the way, what we should also be concerned about is subarachnoid hemorrhage, and if I don't do the procedure, I won't find that out. They only talked to him about meningitis. He never had meningitis. So that is not even close to an informed refusal. That case, if that guy filed a claim, would not even go to court. We would never even try that. There's not an informed refusal. Okay, here's another one. 55-year-old female presents with chest pain. The chart says it's reproducible. Most of the time when docs and nurses write reproducibility on the chart, they're already of the mindset, I'm trying to explain why it's not acute coronary syndrome. Not always, but frequently, okay? The EKG was said to be normal, offered admission and declined, but it wasn't documented. It was after the fact. They said, oh, well, we talked about admission. They didn't want to stay. Why didn't you put it in the chart? But even the nurse said, yeah, he offered him admission. And is this an informed refusal? We offered to have you stay, and you didn't want to stay. What do you think? Well, it might be. I just don't know if we know. Here's the patient's ECG. Is it an informed refusal now? Oh, by the way, you don't want to be admitted, but you're having a freaking MI. Is that an informed refusal? Because you have reproducible chest pain. It's not an informed refusal because you misinterpreted the ECG. Okay, I think it's the last case. 49-year-old patient presents with chest pain. Oh, this is actually one of my cases. EKG and enzymes, screening enzymes, and they were done, and both were normal. Offered admission ×2, and the patient declined. 10 minutes worth of chest pain at 2 o'clock in the morning. His wife forced him to come in. Admission offered, and the spouse discussed with the husband, and he still would not stay. And basically, the patient was offered, this is right from the chart, this is exactly how it was stated. He was alert noted ×4, had the capacity to consent and refuse. We discussed the possibility of acute coronary syndrome, the risks of treatment and non-treatment, and the possibility of death. His wife was present and wanted him admitted. She was enlisted to try and convince him, and he would not stay. He would not stay. That's right, that's right from my chart, okay, a couple years ago. What he further said to me was, I said, you don't have to die at all. If you do have acute coronary syndrome, you probably don't, but if you do, you can just, get this fixed and you won't have any problems. He said, if I'm going to die, I'd rather do it at home with my boys. Like, wow, pretty finalistic. I'm like, I've had this conversation with many patients. I didn't think this guy was going to have a bad outcome more than anyone else. I've said, hey, you probably shouldn't go home. You have undifferentiated chest pain. If you want to go, you can go, but you really shouldn't. And I was glad I had his wife to talk to him. And did he go home and die with his boys? No, he didn't get that done. He died in the car the next day on the way back to the ED. She pulled in. He was in the back, arrested. Dead guy. Is that an informed refusal? Yes. That's an informed refusal. That's the way that needs to look. And you don't have to have them sign something. That case never went anywhere because the family was involved and it was documented well. Okay, radiology discrepancies. Discrepancies are important. We know we've had many issues where our radiology colleagues either have not read a film or have not reported a discrepancy to us so that we can act on it. So we need an airtight system. Radiology has to be accountable, and so does the hospital. We've got to make sure we do the right thing for the patient. We've got to let the patient know within about 24 hours, hey, we missed a fracture, or we missed the appendicitis on the CT. It can't wait forever. We've had cases where it's been months before somebody finds something at a family practice office that radiology faxed over to the office, never told the emergency physician. And that includes things like pulmonary nodules. Pulmonary nodules can become what later? Cancer. And if we wait 6 or 12 months to get the discrepancy reported, or never, then we can have bad outcomes that we could have prevented. Okay, so what are the solutions? Standardize the process. 100% verification of all preliminary emergency department reads should be performed. We should have a list, and this is what we do. We should have a list where radiology says, these are the 20 you read overnight when we weren't here, when we were sleeping. And these either have been identified as discrepant or not. We agree or we don't agree, and then we know everybody's accounted for. Timely resolution and an addendum in the medical record explaining that we know about it and here's what we did about it, it's been resolved. 0 claims in 5 years after that, but we had some claims before that. Okay, that's all I have. If you have any questions, I'll be happy to take them. Otherwise, it's dinner time.